A very good evening. I welcome you all to this webinar of the Chandigarh Ophthalmological Society, an update on pediatric cataract. We are privileged to have with us leading experts in the field who will be sharing their experiences with us today, and we are really looking forward to this webinar. Before we move on with this session, I would like to invite Dr. Jaspreet Sukhija, President of the Chandigarh Ophthalmological Society, to say a few words, please.
Thank you, Dr. Chintan. Good morning and good afternoon and good evening to everyone all over the world. We are privileged here to have with us some of the doyens in pediatric cataract who would be sharing their experience with us and giving us an update on pediatric cataracts in various regions of the world. And my special thanks, and we are honored to have with us Director of our institute, Professor Jagatram, who needs no introduction, and he has so much experience over the years. Thank you, sir, for being part of this webinar. And I would also like to thank our esteemed speakers, Professor Scott Lambert, Professor Maria Musaji, Dr. Sumita, Professor Ken Nischal, for being a part of the webinar. And I hope it's a very lively and interesting webinar for all, and feel free to ask questions. And I'll give the Dr. Chintan here to kindly carry on with the proceedings.
Thank you. I will just introduce the first three of our speakers. So in this update on pediatric cataract, we have Professor Scott Lambert with us, who's a professor of ophthalmology and pediatrics at the Stanford University School of Medicine. He has over 30 years of experience conducting research on the effects of lensectomy on a neonatal eye. And he has been the principal investigator of the infant aphakia treatment study from 2004 to 2020, which is one of the most well-read studies, I think. He has given the R. Jampolsky Day Lecture at the California Pacific Medical Center in 2017. And he's also achieved the Lifetime Achievement Award from the American Association of Pediatric Ophthalmology and Strabismus in 2017. And as recently as 2020, Professor Lambert was also awarded with the Secretariat Award from the American Academy of Ophthalmology. Following him, Professor Maria Musiji will be sharing her experiences with us. She is a consultant ophthalmologist in genetic eye disease at Moorfields Eye Hospital and the Great Ormond Street Hospital for Children in London. She is also professor of molecular ophthalmology at UCL Institute of Ophthalmology and the group leader of ocular genomics and therapeutics at the Francis Crick Institute in London. Professor Musaji is president of the UK Eye Genetics Group, the research lead for the Education Committee at the Royal College of Ophthalmologists, and the president of Women in Vision UK. She has around 100 peer-reviewed scientific publications and been awarded with international and national prizes for her research. Thank you, Professor Maria, for joining us today. Next, we have Dr. Sumita Agarkar, who is the Deputy Director and Senior Consultant, Department of Pediatric Ophthalmology, Shankaranetralaya, Chennai, since March 1999. She did her fellowship from the Arvind Eye Hospital in June 1998. Currently, she is the executive member of the Strabismus and Pediatric Ophthalmology Society of India and the lead ophthalmologist for the Orbis Reach project. She's an avid researcher, active publisher, and been an invited speaker at many international and national forums. Welcome, Dr. Sumit. We have with us Dr. Savleen Kaur, who is an assistant professor in the Department of Ophthalmology at PGI Chandigarh. She is a fellow of the International Council of Ophthalmology, has been a visiting fellow at the Jules Stein Eye Institute, University of California. And she's also a member of the WSPOS Connectivity Bureau. At a very early stage in her career, she is deep into research and has over 80 index papers and over 30 invited speaker sessions, with a special interest in strabismus surgery, imaging in strabismus, and refractive errors in ROP. So Dr. Savleen will be moderating this session for us today. I will now hand over the session to her. And Dr. Savleen, all yours.
Thank you, Dr. Chintan. Good evening, good morning, and hello, everyone, wherever in the world we are watching this update on pediatric cataract. I welcome you all. I hope you're all safe wherever you are. And today we have a fantastic panel with us, and I'm really thankful to all of them for joining us today. We'd like to invite everyone who is watching to type their questions in the comments box on whatever portal they are watching, YouTube or Facebook. And I would now like to invite Dr. Scott for his presentation. While he shares his screen, I would like to just highlight what has already been said. His contribution to the field of pediatric cataract and the pedic studies in particular have been outstanding. It's an honor to have you here, sir. Dr. Scott, please.
Thank you very much. It's good evening. I'm very pleased to be able to participate in this webinar. And this is a topic which is very near and dear to my heart. I started this project the beginning of my career, and I'm still working on it. I'm towards the end of my career, so it's spanned many years. The idea for the project was developed in a conference I attended in London in I think it was in 1996, so a long time ago. So this was we spent many years trying to organize this, and we finally were funded by the National Institutes of Health in the United States in 2004, and it was a randomized clinical trial that we conducted at 12 clinical sites in the United States, trying to determine the best treatment for a unilateral congenital cataract. And we randomized babies to either receive an intraocular lens, be left aphakic, and then be corrected with a contact lens. And to be eligible for this study, the baby had to have a unilateral visually significant cataract that was more than 3 millimeters in size. They had to have had surgery between 1 month and 6 months of age. And the parents had to be willing to randomize their child to either one of these two treatments. So the children were randomized to the aphakic group, or the contact lens group, had a lensectomy, and then were then corrected with a contact lens. And the children who were randomized to the intraocular lens group had a cataract extraction. They had a primary IOL implantation, posterior capsulotomy, and then wore spectacles. And we standardized the treatments among all the different surgeons that were participating in the study. So it was done in a very similar way from one hospital to the other. And these are the results that we published just recently for the 10.5-year follow-up. So we basically follow these children from the time they're babies until they're 10. And we've applied actually to study them one more time when they're 17 years old, and that is being reviewed by the National Institutes of Health this coming summer, that grant proposal. But you can see that the visual outcomes are very similar in these two groups. So the children who were randomized to contact lens, their logMAR acuity was 0.86, whereas the ones who were randomized to the intraocular lens, it was 0.89. So almost the same. The p-value is 0.82. And you can see there was a big range of visual outcomes. So this is the aphakia group, this is the intraocular lens group, and there were some children who had basically normal vision. They were randomized to the contact lens wear, whereas other children had really poor outcomes, a big spread of visual outcomes, but the median was around here. And it was very similar, as you can see, between the two groups of patients. So it really didn't matter the type of correction you had, either contact lens or intraocular lens, in terms of the visual outcome. We also looked at many different factors. And one of the things we looked at was whether there's a way of predicting which children would have a good visual outcome and which ones would have a poor visual outcome, because we obviously would like all of them to have a great visual outcome. So we looked at things like the age of surgery, the type of cataract, socioeconomic factors. We found that the age of surgery was significant. Certainly children who had surgery between 4 and 6 weeks of age had better outcome than children who had surgery from 7 to 6 months of age. And this was highly statistically significant. We didn't find that the type of cataract made a difference. Our theory was that children who had a partial cataract, like a Meller cataract or lente globus, that they would have a better visual outcome, but in fact, we weren't able to show that was the case. But perhaps the most important factor for the outcome was the type of surgery or the type of insurance they had, even though in the study, everything was paid for. Their contact lenses, the glasses, the patches, they're all paid for by the study. But despite that, children who had private insurance had a much better visual outcome than children who had public insurance. And we think this sort of reflects the socioeconomic factors, such as many of these patients had only a single mother taking care of them, where these were more a family situation. These families might have had more difficulty with transportation, things like that. So that was a big factor in terms of the outcome, was the type of insurance they had. We were also really interested in looking at transportation, things like that. So the refractive error in these children that were randomized to the pseudophakic group. And we undercorrected them by 6 to 8 doctors at the time of surgery. But despite that, when they were age 5, they on the mean refractive error was a -2 diopters of myopia. And by the time they were age 10, it was almost...
Sorry, I couldn't hear what you said.
It was approaching 6 diopters of myopia. And we found that 35 to 36 eyes became more myopic between the age of 5 and 10.5 years. So there's a continuing myopic shift in these patients. And that's one of the challenges of implanting intraocular lens, is trying to predict how much the shift is going to be. And I think more and more of these children are going to have their IOLs exchanged as they become older, because they're so myopic in these eyes. I saw a patient in clinic the other day who had a IOL put in one of his eyes when he was 2 years of age by somebody else. And he's now has a -14 refractive error in this eye. And so I'm planning to do an IOL exchange. We also looked at the issue of anisotropia, and we found that the pseudophakic eyes had a very large amount of anisotropia at the age of 10.5. The ones that were the non-glaucomatous eyes, it was about a -6 diopters of anisotropia. The eyes that were glaucomatous, it was 12 diopters of anisotropia, which is a very large amount. So the variability of eye growth and the myopic shift continues to be one of the challenges of implanting intraocular lens in a baby's eye. We also found that the children who had an IOL implanted, they tended to need a lot more additional surgeries. And it was, in the most part, it was because they developed these visual axis opacities that had to be cleared. So in the IOL group, 68% of them had to have some type of surgery to clear this visual axis opacity, even though they had primary posterior capsulotomies, whereas in the contact lens group, it was only 14%. So this was a very highly significant difference. The p-value is 0.001. Otherwise, their surgeries they had were similar between the two groups. We also looked at their motor skills at the age of 4.5. We had a traveling examiner examine their gross and fine motor skills using this movement assessment battery for children, the MABC2 test. And we found that children who had a cataract tended to have worse scores. On their mean score was in the 18th percentile, and 40% of these children had scores less than the 5th percentile. We published this in the Journal of Developmental Medicine, Child Neurology in 2015. So on the basis of this, we recommended that children with visual impairment secondary to unilateral congenital cataracts, they may have delayed motor functioning, and this should be something that pediatricians should be aware of, and they should take the appropriate steps to try and address these motor delays in these children. One of the requirements of being in the study is that these children had to have no other systemic diseases, but we found, in fact, that over time, 4 of them did have diseases that we were unaware of at the time of enrollment. One of them turned out to have mitochondrial disease. One had autism, one had Stickler's, and then one turned out to having congenital rubella syndrome. But none of the fellow eyes developed cataracts. So of the 114 patients enrolled in the study, they were all unilateral. There were 2 patients who the fellow eyes developed reverse amblyopia secondary to anisotropia. So they actually ended up having better vision in the treated eye compared to their fellow eye. So our conclusion from this study was that while operating on an infant younger than 7 months of age with unilateral cataract, we recommend leaving the eye aphakic and focusing the eye with a contact lens. Primary IOL implantation should be reserved for those infants where, in the opinion of the surgeon, the cost and handling of a contact lens would be so burdensome as to result in a significant periods of uncorrected aphakia. And I've heard ever since we published this in 2014 that this is not really a great solution for many parts of the world because they don't really have access to contact lenses. But I would say this is certainly what is done now in the United States. I think there is a lot of reluctance to put intraocular lenses in babies' eyes because of the reasons I just mentioned. But it may be still in some parts of the world where they don't have contact lenses, it's still a better option to use the intraocular lens versus leaving them aphakic. Thank you. Let's see, I'll stop.
Thank you, Dr. Scott. It was an absolute delight. It was a wonderful recap of whatever we have ever read about the IATS. And we plan to take questions at the end of the first 3 talks. And so I have a lot of questions. I'm sure the audience keep typing. While I invite, it's a pleasure to invite Dr. Maria Musaji for her talk. She would be talking about genetic testing in pediatric cataract. Dr. Maria, please.
Thank you, Dr. Savleen. Thank you very much, Dr. Jaspreet, for inviting me to speak to you all this afternoon. So yeah, it's my pleasure to give you a bit of a whistle-stop tour on genetic testing for childhood cataract, when and why. So we know that worldwide, 20,000 to 40,000 children are affected with congenital or childhood cataract every year. Now, if we take away any patients that have an environmental cause, then autosomal dominant inheritance is the most common, accounting for 44% of cases. We know currently that there are over 115 causative genes that involve genes that are encoding proteins that are lens specific and also transcription factors that help the eye develop. And patients with bilateral cataracts have between 50 to 90% chance of getting a molecular diagnosis through genetic testing. So why is genetic testing important? Well, patients and families want to know why their child or they have developed a condition or a cataract in this case. For us doctors, it's important that we think about disease associations. Is this young baby presenting with an isolated cataract, or do they have a possible syndrome? For example, if they have mutations in the OCRL gene, it causes Lowe syndrome, which we know is an X-linked recessive disorder, also characterized by hypertonia, intellectual disability, and renal dysfunction, such as proximal tubular acidosis and proteinuria. And so we need to get the right multidisciplinary team involved. We can provide informed genetic counselling and go on to offer family planning. So that could include pre-implantation genetic diagnosis or non-invasive prenatal diagnostic testing for families. It helps us to develop potential treatments and also for patients to access the latest research. So how do we currently undertake genetic testing for children presenting with cataracts? Well, we use something called targeted gene panels. And this is an example of all the genes that are known to cause non-syndromic and syndromic cataract in children. And what we do is we look at the coding regions of these genes. So we look at the exons in the genes and we look for potential mutations that are residing there. We don't currently look at the intronic regions or intergenic regions. And that's because traditionally most mutations lie within these coding regions. But this coding region only looks at a small part of the whole genome. So if we looked at the coding regions of all genes, it only accounts for 1 to 2% of the entire genome. So what results are we getting from looking at these targeted gene panels? Well, Graham Black in Manchester has done a huge body of work on this. And this is one of the papers which describes where he looks at 50 children that presented with cataracts, and he found a 75% molecular diagnostic rate. Now, this can range, as I said, between 50% in certain studies and up to 90% in other studies. However, we have to look at the N number that are used in some of these studies so that we can get a good average idea. But if you were counselling a patient in clinic, it would be best to say they have up to a 80% chance of getting a genetic diagnosis if they present with bilateral cataracts. So what happens to those where we don't find a genetic result? Well, we're now moving to using a test called whole genome sequencing. And this is where we can sequence all 3 billion nucleotides within our genetic code and look at all 20,000 genes. And we don't just look at the coding regions, those exons, we also can look at introns and intergenic areas, because we are now finding mutations in regulatory elements that are outside of these coding regions. We screen for the known genes, but it also allows us to interrogate for potential novel genetic causes. So our experience at Moorfields using whole genome sequencing showed that when we sequenced 70 patients with bilateral congenital or childhood cataracts, and bearing in mind that 20% of these patients had a negative genetic result from previous targeted panel testing, we had a diagnostic rate of around 54%. And you can read more about this in this publication here. So when should we be undertaking genetic testing? Well, the answer is as soon as possible, because obviously we can undertake traditional investigations such as the torch screen, urine analysis, karyotyping, and urinary and plasma organic amino acid testing. However, again, studies have shown that for patients to actually get a diagnosis, it can take over 56 months. And even in a trial of this, only 1 out of 27 patients actually ended up with a definitive diagnosis, compared to a 75% diagnosis that can be reached through genetic testing. So how do you undertake genetic testing? Well, for these targeted gene panels, which are based on exome-based tests, you can take a blood sample or a saliva sample from a patient and extract the DNA from that. It's really important to take a detailed family history, ask about consanguinity, and ensure you know the ethnicity of these patients, because there are certain variants that can be more common in certain populations, but actually disease causative in others. Make sure that we ask a detailed history about the ocular and any systemic features. And then, as I said, you can request these gene panels, which include about 115 genes, and the turnaround time, depending on which company you use, can be between 1 to 6 months. So I'm just going to give you a couple of cases just to show you the importance of doing genetic testing. So case 1 is an example of where you can identify syndromic disease, and there can actually be a potential treatment. So this is a 13-year-old Bangladeshi girl that presented to our clinic, and she was wearing glasses for myopia from around the age of 7. She developed these blue dot cataracts around the age of 11, and her past medical history included learning difficulties, delayed speech, and asthma. Her parents were consanguineous, but there was no other affected family members. And on examination, she had microcornea and these blue dot cataracts. Her visual acuity was 0.7 logmar in both eyes, and her pressures were normal. So we undertook whole genome sequencing, and we found that she had homozygous mutation in the CYP27A1 gene. And this gene is known to cause a condition called cerebrotendinous xanthomatosis. Now, cataracts are the most common presenting feature in this condition, but in infancy, children can suffer from chronic diarrhea or cholestasis, but that often goes undetected as a short period of failure to thrive. Later on in childhood, they can suffer from tendon xanthomas. And then as they get older into adolescence and adulthood, patients start to develop neuropsychiatric disturbances. They can get increased muscle tone, ataxia, dystonia, and seizures. Now, patients can be referred to pediatric neurology, and they can actually access a treatment called chenodeoxycholic acid, which, if started before the age of 25, can actually improve symptoms and halt disease. But unfortunately, studies have shown that most of these patients actually get a diagnosis around the age of 35, despite presenting with childhood onset cataracts. And this is an example of where doing genetic testing early can lead to early diagnosis and early treatment that will reduce morbidity. The next case is an interesting case. Don't assume environmental factors. So this is actually a 28-year-old Arab gentleman who presented to our clinic who had a history of bilateral congenital cataracts. He had bilateral lensectomies aged 10 to 12 weeks of age, and he developed secondary aphakic glaucoma by age 5. Currently, his hand movements, his vision in the right eye is hand movements, and in the left eye it's 6/24, and the pressures are controlled at 13. So his family history, well, there wasn't one, and there was no history of any consanguinity. Now, his mother had reported having serological testing for toxoplasmosis during the 3rd trimester of pregnancy. So throughout his life, he had been assumed to have maternally derived toxoplasmosis-related congenital cataracts. But he presented to the genetics clinic asking about his risk of having affected children. And when the consultant, it wasn't me, it was my colleague, said to him, no, you're very low risk of having any children with this because we believe this is an environmental cause, he replied back and said, are you sure? At which case, obviously, the consultant couldn't be sure and undertook whole genome sequencing for the patient because it happened to be available. And lo and behold, his genetic results came back with a heterozygous missense mutation in the CRY-BB3 gene. And the mutation was found to be de novo sporadic. So it had occurred just within himself. His parents did not pass on that mutation. And this is known to cause autosomal dominant non-syndromic cataract. Now, this gentleman now has a 50% chance of having an affected child. And so he was referred for family planning. And so he and his wife then undertook pre-implantation genetic diagnosis to ensure that his children would not be carriers of this dominant mutation. So if any of you are interested in learning a bit more about genetic eye diseases in general, and in particular congenital cataract, we launched this website, gene.vision, in December last year. It's a knowledge sharing resource for both professionals and patients. The professionals can access all this information, and there is a page reflecting this written in lay language for patients in case you want to signpost them to this. But it talks to you about inheritance patterns, how to undertake genetic testing, and goes through some of the genes that are involved in both non-syndromic and syndromic congenital cataract. So just to conclude, genetic testing will help you reach a diagnosis. It will guide your management in terms of recruiting the right multidisciplinary team so that we can especially reduce morbidities in children with syndromic cataracts. And around 15% of children presenting with bilateral cataract can have syndromic features. It also provides patients with access to family planning. And again, this is for just a learning paper. If any of you are interested in really having an in-depth read into all the genetic causes of congenital cataract, this is a nice review that we published last year. So with that, I'd just like to thank my team and thank you for the invitation to speak today.
Thank you, Dr. Maria. It was actually a real world scenario of how syndromic and non-syndromic conditions can cause bilateral cataracts and how do we approach them. For the audience, we have a lot of questions, and I would ask them to continue typing so that we can take all the questions at the end of the next talk. And now I invite Dr. Sumita for her presentation. She would present, she would be talking about infantile cataract and probably would present an Indian scenario, and how does it differ from the West? Dr. Sumita, please. You would have to unmute yourself, ma'am.
Dr. Sumita, please unmute. Yes.
1 second. Yeah. Thank you for, I would like to first thank Dr. Jasprit and Chandigarh Ophthalmic Association for giving me this opportunity to speak in a webinar. The August company which is here is frankly makes me nervous, but thank you for thinking of me. When I say infantile cataracts, in Indian scenario, very few of our children really present that early. So I would consider whatever is under age of 1 probably will fit into this criteria what I'm talking on. So is it different in infants? Yes, it is more likely to be related to intrauterine infection, especially in our country. Children who are presenting that early are more likely to be associated with ocular and systemic comorbidities. And needless to say, they are anatomically more challenging than even what difficulties we face in older children. Now, basically, these are the questions which you need to answer. Timing, when should we operate? What are the investigations and surgical tips and tricks? Correction of aphakia and follow-up of these children. So how early is early? Now, sometimes children do present at the age of 10 days and 15 days. And I have the earliest kid I have operated is probably in the start of my career at the age of 3 weeks. But I think early surgery, there are various studies which have proven that early surgery does increase the risk of glaucoma post-surgery in these patients. But this has to be carefully weighed against the risk of deprivational amblyopia. Both Dr. Birch and Dr. Lambert have recommended surgery by the age of 6 to 8 weeks because operating before 6 weeks versus operating at 6 weeks does not seem to change the visual outcomes majorly. However, this may have to be modified. This decision may have to be modified by child's fitness for anesthesia, systemic conditions, and sometimes in our scenario, even the parents' willingness to operate. Because sometimes even if we tell the surgery, they take their own sweet time to come decide and come for surgery. Pre-op evaluation is routine that we would do for any pediatric cataract surgery, but probably in these children, pre-op evaluation and during anesthesia is probably you should take that opportunity to do a good evaluation under anesthesia. It is good idea to document corneal diameter, axial length, pre-op intraocular pressure and keratometry, and if possible a gonioscopy if you have the access to it, because all of these parameters do have an importance should the child develop glaucoma or a suspicion of glaucoma. So sometimes these parameters can be used to detect and diagnose. And of course, if you are planning an intraocular lens, these children are unlikely to cooperate in clinic for biometry, so you may have to plan for a biometry under anesthesia. Surgery, most of this surgery can be done through side ports, luckily, because most of these cataracts are very soft. Making a side port using an MVR blade rather than a 15-degree blade is probably a better idea because it keeps the chamber form. Capsule in these children is very elastic, but occasionally be prepared for occasional surprises in terms of very fibrous capsules. You may sometimes encounter a dense calcified nucleus, which is very difficult to aspirate, and you may have to have some other options ready for these patients. It is very useful to have a cohesive OVD, and staining agents like trypan blue have made life really easy for all the pediatric ophthalmologists. PFV and postcapsular dehiscence also may have to be anticipated and may complicate the posterior capsular, sorry, this is a typo there, may complicate your posterior capsulotomy, and you may have to be prepared. So as you can see all types. This is one child where you can see there is obvious microcornea, a nuclear cataract, just the way you would very typically see in rubella. In our country, rubella is still very, very common in infants, and as you can see, there is corneal diameter is just about 9.5 millimeter, and here probably there is no role for putting an IOL when the baby is just around 6 months. And luckily she dilates well, but a lot of children with CMV related cataracts sometimes don't dilate well, and you have to be prepared. Compare this to another infant who has a nearly normal sized eye and good dilatation, and surgery is probably not any different from any other child where you can easily aspirate. And as I said, most of the surgery you can finish using side ports, and all you have to do is just after finishing your, probably before starting your posterior capsulotomy, you can open your thing, and vitrectomy has to be whatever the cut rate which is maximum offered by your patient, by your machine, and this is probably possible to put an intraocular lens very nicely in the bag in this baby compared to the other. Sometimes, as I said, you can encounter a really fibrotic capsule, as you can see, and here you may actually have to use an MBR blade to make an opening and complete the anterior capsulotomy using scissors, or because sometimes you can't use a vitractor to cut to make an opening in these kind of capsules, and your 23 gauge vitractor sometimes is just not able to cut through these kind of capsules. And then once you have made an opening, then you can go ahead and use a vitractor to enlarge the opening. Luckily, if they are difficult to make the opening, they don't extend either. So risk of extension is also less in these patients, even with jagged irregular edges. Sometimes, as I mentioned earlier, you can find a really dense nucleus, and this baby, I was not planning to put an IOL, and as you can see, so much of struggle. It's like a nucleus, and I wish I had a slightly larger opening to use a phaco probe to aspirate it, but somehow it took me 30 minutes to actually aspirate that nucleus, which this 6-week-old baby had. Again, very common scenario, posterior PHPV, or as the recent term, persistent foveal vasculature. And again, these patients don't dilate, can have really small eyes, and can have dense synechia, which makes them prone for a lot of manipulation during surgery. And sometimes later on, the risk of glaucoma is also really high in these children. So this is one child where you can see there is only a vascularized membrane, and there is really no true lens here. And despite my using a lens hook to stretch the pupil, I was not able to get a good sufficient amount of dilatation. Since I was not planning to use an IOL here, I actually used a vitractor to do a little bit of pupilloplasty to allow me slightly better visualization of the surgical field. And as you can see, there is a lot of vascularization and bleeding during surgery, and you probably have to use a cautery. A 23 gauge cautery can be used to cauterize all the vessels which are there on the surface of the lens, and you may have to use a 23 gauge cautery, which is very effective to cut the bleeding, and then it is like any other surgery, and you can definitely go ahead and make a sufficient opening and do a vitrectomy and clear the visual axis without the risk of bleeding. Sometimes, as I mentioned, you can have a posterior capsular dehiscence. Like this child, it is very anticipated posterior capsular dehiscence because the nucleus is almost, the cortical matter is looking like it's in the anterior vitreous, and there is a kind of membrane there. And here, since I was prepared for it, I actually used a vitrectomy probe only to aspirate the lens. You should keep the bottle height low where you can anticipate. And if you are planning to put an IOL, it is a good idea to make a rhexis which is slightly smaller, because the dehiscence which is there in the posterior capsule may be quite large, or sometimes you cannot convert it into a PPC, and you may have to put the lens in sulcus in these patients. So good thing about children is, since vitreous is very well formed, there is very little risk of cortical matter going down, and you will be able to aspirate most of it without any difficulty. And then you can go ahead and enlarge the posterior capsular opening, which has a neat dehiscence here. And this is actually easy because the dehiscence has nice fibrosed edges, and you can very easily put the lens in the bag in these patients. Sometimes what looks like cataract may not be actually cataract, and this under the anesthesia, this child had iris bombay, plastered iris all over, but we were able to kind of create a small opening, and we found it was just a tunica vasculosa lentis, and there was just a membrane which we were able to cut and do a little bit of pupilloplasty, and lens was clear, luckily for us and for the child, and you really didn't need anything major apart from just a small pupilloplasty, which and this has been 3 years. This I've been following this child with not, so far has not developed a cataract, but has clear visual access, but is amblyopic a little bit thanks to the deprivation. And he came to me at the age of 6 to 8 months when the parents noticed that color of the eye had changed or something. So lens was clear. So it's probably not everything which looks like cataract may be a cataract in infants. So correction of aphakia, again, glasses are bilateral cataracts. Glasses are probably equally good compared to intraocular lenses, especially in infants. If you don't have a good access to the biometry, please go ahead and leave the child aphakic. You can correct it with glasses and put the secondary lens when he is a little older. I have experience with contact lenses, both soft and RGP, and unilateral cases. Sometimes I have used RGP, but in our conditions with the people living in villages, sometimes access to the replacement lens as well as solution is always very, very dicey. So intraocular lens is always should be kept an option in where you feel that you can do it. We have just heard Dr. Scott mention that it is not probably same in all the countries which are there, but in our country, again, if it's a bilateral cataract, I tend to. So probably in 2021, which are the IOLs, which are the infants I would put IOL, probably it's an anatomical decision, really, not really dependent on the age or laterality. I would consider the factors like corneal diameter. So if the corneal diameter is at least 10.5 millimeter or more, axial length is at least 18 millimeter with no ocular comorbidities and good pupillary dilatation, I would offer to put an intraocular lens in a very young child. I would also consider socioeconomic factors like ability of parents to come for follow-up and whether they will be able to replace a contact lens, especially in unilateral cases. But I tend to put more IOLs in unilateral cases than in bilateral cases. And of course, you should have availability of other services because this is a multidisciplinary approach when it comes to infants, and you must have that access to other departments as well. Follow-up is lifelong, and surgery is just the first and the easiest step on a very long road. These children need lifelong follow-up in terms of glaucoma, visual access opacification, detachment, and amblyopia. They need refraction, IOP, and disc evaluation and dilated fundus evaluation on every visit. And I have recently found that wide-angle imaging is very, very useful in as young children as 1 year old for follow-up because it gives you far more information in one shot than it is available on examination. So please feel free to use wide-angle imaging like Optos or something because it gives you really good information. Thank you for your attention.
Thank you so much, Dr. Sumita. We have a lot of congratulatory messages on from our viewers, and those were beautiful videos. And I also have a few questions, and I would like to direct them to Dr. Scott, please. Our audience wants to know that what is the target refractive status that you keep when you are planning a case of surgery in a unilateral case? And a related question to that is that once you now see the refractive outcomes of at 10 years, do you feel that you need to change your target refraction post-operatively when you're operating on infants?
Yeah, so in the study, we undercorrected the children who were between 6 and 8 weeks of age by 8 diopters, and those children between 7 and 6 months of age by 6 diopters. And we should have undercorrected them by a lot more, because I think we found on average that we should have undercorrected them by more like 10 diopters. But that said, I'm not really putting IOLs in babies anymore because of the other problems. But I would say the other problem is sort of how you correct this large degree of hypometropia in this baby after surgery. So let's say you leave the baby 10 diopters undercorrected. Are you going to then use glasses or contact lens? Are they going to wear the contact lens and the glasses? So there's many difficult questions to answer. So I don't think there's a great answer. And that's really, in my mind, probably the biggest challenge to putting an IOL in a baby is trying to know what power of lens to put in. Again, I saw a child just in clinic last week who the other doctor put in a 30 diopter lens in this child. And I went to do an IOL exchange, and I calculated the child needs really a 14 diopter lens in the eye. So how could this doctor have known that at the time he did the surgery, that this child would need a 14 diopter lens instead of 30 diopters? It's a very challenging area. And that's the beauty of contact lenses. You can change them. And I think after the first year or two, there isn't that much ocular growth. So at that point, if you put a lens in, you're more confident that it's going to be closer to what this child will need when they're older.
Thank you, Dr. Scott. So you're saying that we keep a target refraction of say +8 or +6 in case the IOL is being planned. I think the Indian scenario.
That's what we did. I don't think that's right necessarily. That was what we chose to do in the study. I think you'd actually have to do a lot more than that to have any chance of this child being close to emmetropic when they're older. Yeah.
Right.
So Professor Jagatram's.
Yeah, I would like to ask the panel, sir, because what is your target refraction for the audience benefit that you like to keep in when operating on a cataract unilaterally in a child, in an infant?
It is almost similar. I also used to do similar +8 or so, but with the passage of time, I found that many of the children they still have this. It takes a longer time to become them emmetropic and ultimately myopic. Similar, but now I have reduced it to 5 to 6 diopter depending upon the age. Mostly this is particularly for these infants.
Thank you, sir. Dr. Ken, your views, please.
Yeah, so
you put an IOL in an infant?
Yeah, so I do put IOLs in infants, but I don't put them necessarily in unilateral cases. I think if you have a unilateral cataract due to PHPV, they really don't do well. But if you have, for example, a unilateral cataract in a 5 or 6 month old due to posterior lenticonus with normal vasculature, normal sized eye, they actually do very well. And I think that the issue here is when you aim to put an implant in, there are 3 things that you have to understand. The first thing is, what is the other eye doing? Is it a completely normal eye? The second thing is, I try to do +8 if the child is 6 months or younger. And the third thing is that you have to polish the anterior capsule really, really meticulously. And the reason you have to do that is because the phimosis that you get and the fibrosis you get affects your peripheral retina. If you don't understand emmetropization, then you can't really understand what happens when you put an implant in an infant's eye or even a toddler's eye. And you have to understand that. When you put the peripheral retina into darkness, you are going to drive axial myopia. And if you don't believe me, look at the studies from the 1970s and 1980s by David Troilo in animal models that showed this very clearly. So polishing is important. If you get phimosis, you have to go back in and open that phimosis up if you want to prevent large myopic shift. And the studies are there in animal models, very clearly there. So I go for a +8. I do less unilateral. Probably I stopped doing less unilateral in 2004 when I saw that in the PHPV eyes, they got complications, but non-PHPV eyes don't get the same complications. And I would say that it's very important for the audience to understand that a bilateral congenital cataract due to a crystalline gene mutation is a different animal, a different planet, a different universe to a unilateral cataract due to PHPV. And comparing the two is worse than comparing apples to oranges.
Good point, Dr. Ken. I think we have a lot of questions again. You have stimulated a lot of questions. Again, one question for Dr. Scott. Since we have the secondary outcomes being discussed at 10 years, and some of the children had an IOL in the IATS implanted at, say, 4.5 years of age. So now do you actually feel the secondary procedures are the same? And then a related question is that how early would you implant? What is the cutoff age where you would implant a secondary IOL in these children?
Yeah, so we've published one paper in secondary IOLs in these patients, and we're in the process of publishing a couple more. But the interesting thing is that we assumed that all these children were left aphakic, that they would all want secondary IOLs once they were maybe like 5 years of age. And in fact, many of them continue to wear contact lenses. We only had about, I think 24 of them that had a secondary IOL out of the 57 that randomized aphakia. And the other ones were either wearing contact lenses or the eye had grown so much they actually did fine just with glasses. Many of them had a very low hyperopic refractor, like a +4, +3. And so they didn't really need a secondary IOL. So that was kind of surprising to us. And then the ones that were wearing contact lenses and were doing well, they didn't really want to take the chance of having another surgery and putting the secondary IOL in. So they were perfectly happy to continue to wear the contact lenses. And those were actually some of the patients who had the best visual outcomes. There was maybe like 20 patients, probably like 20 patients who really were seeing well with the contact lenses and were perfectly happy to carry on. So the one advantage of waiting to put in the secondary IOL is that they tended to have less a myopic shift, and so it was more predictable. And so we showed that there was, they were closer to being emmetropic than the children who were made pseudophakic right from the beginning out of primary IOL implantation.
Thank you, Dr. Scott. I have a question for Dr. Maria. If you have an isolated cataract and just no syndromic association, would the morphology guide you into genetic testing?
No, I mean, at the moment, we don't know if there are clear genotype-phenotype correlations. Just to say that the rates for bilateral cataract are much higher for getting a genetic diagnosis than unilateral cataracts. So I think, I mean, we need to do a little bit more work on bigger cohorts. Some of the problems is that we have descriptions of what the cataract looked like, but we haven't actually taken pictures of them in a lot of cases. So when we go back retrospectively to do those correlations, we can't do that. But prospectively, I would urge everyone, when you do genetics, to try to take a picture of that cataract on the table so that we start to feed into that information a bit more.
So I have a question for you, Maria. So how often do you find some type of syndrome or disease that's treatable when you do this genetic testing on these children with cataracts?
So as I said, like, it depends. I mean, you know, on average, they say there's about 15% association with syndromic features. Now, we're actually seeing a lot more patients. It's difficult. So a lot have behavioral problems. They can have learning disability. They have global developmental delay. You can do things like array CGH to look for any kind of copy number variations and stuff. And and it's not necessarily that you'll get a treatment, because the treatment essentially is you have the cataract surgery, but it's the management of the systemic features. So it's picking up the fact that there may be cardiac defects or renal defects, and making sure, or neurological defects, that you refer those children to the correct multidisciplinary team. So all children should be looked after by a pediatrician who would do general testing. But it's just that going through all those systems can cost a lot, and it can also take some of these children. So, I mean, you know, the other thing just to note is that we did a study of children presenting, or children and young adults under 25. And some children presented with cataracts, but actually had a retinal dystrophy as well. And that was undetected because the cataract was the presenting feature. And so that is another thing just to bear in mind, that it's not just, you know, isolated congenital cataract. It could form more ocular morbidities, syndromic morbidities that we can further investigate and manage properly.
Yes, so I would say in my practice, the only thing I do now to work these children up really is genetic testing. I don't do the blood tests, these do the torch titers and all those things. Yeah. And I've found to be much more successful, and it's actually not that expensive in the United States. There's a there's a company in San Francisco that will do the testing for $250. So it's not a big expense.
Yeah, I think if you had to choose, that would be the one you'd want to do, really.
Yeah.
Sure. I'd like to just say that there's going to be many people listening to this who just the parents can't afford it, the institution can't afford it. I think that the two things that are really important, you must do a dilated examination of the parents.
Yeah.
Dilated one. Doing a non-dilated examination of the parents to look at the lens is a waste of time. There are a number of times, many times, where you pick up peripheral cortical changes that you would not pick up on a non-dilated pupil. That's very helpful because that could be an isolated, a lens-specific gene, like a crystalline gene. And then the other thing is you've really got to take a really good pedigree. We've picked up a number of patients who we'd never have thought of doing COL4A1, for example, where there's a strong family history of strokes at a young age. And these children have COL4A1 gene mutations causing cataract. So for those of you who don't have access to genetic testing, examine the siblings and the parents dilated and take a good pedigree, because that will give you an inclination as to what's going on. And if you have microcornea with cataract, that's even a more strong indication that you check the family history out. And we're hoping to put together a compendium of signs and symptoms that will lead to specific gene evaluation. I've got 3 families with BMP4 related cataracts, and each family has a history of thyroid disease. So all of these things, once we put this paper together and all of us are working together in a network to help people around the world who don't have access to genetics, to use the clinical signs to help figure out the likelihood of what might be going on.
Yeah, I just want to reinforce what Ken's just said. I think the more we can put our cohorts out there, the more clearer picture we'll have. I mean, inherited retinal dystrophies are leagues ahead of us in terms of their phenotyping, but actually genetically, bilateral cataracts have a higher rate of diagnosis than them. So if we can just pull that data together, if you have, patients with similar features, and obviously I do appreciate genetic testing, is expensive. If you have the capacity to apply for some research funding so that you can do that on those cohorts, take the history is so important, and you can rule out whether this is down to an environmental factor and focus on those ones that you think may be genetic.
Thank you. We have a few more questions, which I can, if time allows, we'll take it after the next set of talks for Dr. Maria. For Dr. Scott, if I could have just one comment. There is a higher incidence of aphakic glaucoma compared to pseudophakic. Do you think IOL is to be blamed? In fact, I think I would invite the whole panel to talk about it a little bit. Aphakic glaucoma versus pseudophakic glaucoma.
Yeah, so there's this notion out there that somehow putting intraocular lens in protects your eye from developing glaucoma, but we did not find that true in our study. These children were randomized, and the problem with a lot of these other studies that the children who received intraocular lenses were different from the children left aphakic. So in these studies, they were randomized, and we just published, or it's actually in press in JAMA Ophthalmology, showing there was no difference between the rate of glaucoma in the children who were made pseudophakic versus the ones that were left aphakic. So I think that it's actually a high rate of glaucoma in both groups. It's quite high, and it seems to be age related. So the younger you have the surgery, the more likely you are to develop glaucoma. And so it's sort of this balancing act between trying to preserve their vision, but also not causing glaucoma. So there's been sort of this movement away from doing really early surgery. I think sometimes in the past people would do surgery before 4 weeks of age, and now I think people are moving more towards doing surgery between 6 and 8 weeks of age. And doing at that age, you generally have a great visual outcome, but you also have a lower risk of glaucoma. For every month younger that you do the surgery, the rate of glaucoma increased by 50%, we found in our study.
So does vitrectomy have you can say doing vitrectomy will cause a higher incidence of glaucoma? Because the vitreous, they say it's known to create a hypoxic environment around in the anterior chamber around the lens. So once you remove the vitreous, probably the oxygen-free radicals would cause some damage to the trabecular meshwork. And this was a study published in probably AJO a few years back.
Yes, so I don't think we really know why these eyes develop glaucoma, but all the children in my study had vitrectomy, so that was a common factor. But maybe that is a factor. But I think it's still an area of the somewhat unclear what causes glaucoma in these eyes. But I presume it has something to do with immaturity of the trabecular meshwork, and somehow by doing surgery on their eyes, you somehow disturb that maturation process so that it doesn't function normally.
Yes, we need to reiterate that the timing of surgery is an important factor, not perhaps the IOL, which is causing the glaucoma.
Yeah, I think that's correct.
I have to say that there was a couple of really good papers done by David Walton, which for some reason, well, I know that they were published in the Transactions of the American Ophthalmological Society. David Walton showed very clearly with his group of workers that exposure of lens epithelial cells to the immature trabecular meshwork causes the meshwork cells to take on the appearance of what you see in open angle glaucoma in 40 and 50-year-olds. That if you can prevent lens epithelial cell exposure, it was also published in IOVS, and I'm not sure why people haven't taken to this, but the papers are really good papers. And I think that it's the exposure of lens epithelial cells to that meshwork. What's really interesting is that Noel Rice at Moorfields years and years ago said that he didn't get any aphakic glaucoma, and people just laughed at him. But the fact was that when he did pediatric cataract surgery, he used a cryoprobe to take the whole lens out. So there was no lens epithelial cells left behind. So I think this whole issue of the IOL being protective is, if, in my opinion, pediatric cataract surgery, especially in infants and toddlers, is a real world issue. And while, I think the IATS is a great study, I think that it created an artificial environment, both for the surgeon and for follow-up, that's not reflected in real world practice. And in real world practice, we all have our experience, which tells us, I'm going to implant this one, I'm not going to implant this one. And so when you look at the retrospective data, and there was an individual meta-analysis, which some of the people on the panel had contributed patients to, we found, it was done by Amina Matafsi, that there was a protective effect, but and this was, I think, 566 eyes in children under the age of 1, but the surgeons chose which eyes to have implants put in. And I think that's really important. I mean, even in the IATS, there was a paper published about the fact that some surgeons use methylprednisolone intravenously, while some didn't. So it's difficult to do an RCT with IOL implantation being the sole only variable. It's impossible, in my opinion. But it has given us some food for thought and food for discussion.
I think it's like a debate unending. And since we are running short of time, I hate to interrupt you, Dr. Ken, but I would like to go on with the second part of our webinar. And I would like to invite, in absolute privilege, to have Professor Ken Nishtil with us, who is the Chief Division of Pediatric Ophthalmology at the UPMC Eye Center and University of Pittsburgh School of Medicine. He's one of the pioneers of pediatric corneal transplants. His main areas of clinical research are the anterior segment developmental abnormalities. And people come to him from all over the world because of his helping with the genetic corneal diseases. His main area of research focus is evidence-based protocol-led clinical care in the same area. He has published widely on the topics of pediatric cataracts, glaucoma, and cornea. And he's also the co-founder and director of the World Society of Pediatric Ophthalmology and Strabismus, an outstanding organization with members from around the world. Thank you, Dr. Ken, for being with us today. It's an honor for me to be inviting our director and professor of ophthalmology at the Advanced Eye Center, Postgraduate Institute of Medical Education and Research, Chandigarh. He has been recognized internationally for his outstanding contributions in cataract and refractive surgery. He's a personal inspiration to me and all of us at this institute. And he has a number of awards, and I would not be doing justice if I start talking about his awards. Just to name a few, best of the best at the ASCRS San Francisco 2013 and also at New Orleans, USA. He also won an Oscar in pediatric ophthalmology in Barcelona 2015. He's an excellent teacher. He has contributed to over 450 lectures worldwide, contributed to 300 research publications, is an inspiration for all of us, a clinician par excellence, and for his exceptional surgical qualities, he was awarded Padma Shri by the Honorary President of India in 2019. Not often do we get an opportunity to welcome our own mentor. So Dr. Jasprit Sukhija, I feel lucky to be welcoming him here. He has been managing the pediatric ophthalmology services in PGI since 2006 with over 100 publications to his credit. He has an associate editor of the Acta Ophthalmologica with a number of awards, including the Orbis International Gold Medal at ESCRS, at the North Zone Ophthalmological Society, the Hanumantha Reddy by the AIOS, and a gold medal by the IRSI. He has been an invited speaker at various international and national forums and a reviewer for many journals. I welcome all of you for the second part of the webinar. And now I would like to invite Dr. Ken for his talk, please.
Thank you. It's a great pleasure and honor to be speaking today with everybody that's on the panel. And I was asked by Jasprit to speak about pediatric capsulorhexis, the 2-incision push-pull technique. These are my disclosures. Since I got the United States, I have more to give than I did have when I was in the UK, but I am, of course, the executive co-director of the charity, the World Society of Pediatric Ophthalmology and Strabismus. None of these are relevant to my talk today. So the reason why I actually developed the 2-incision push-pull capsulorhexis was that during my training, I would see very experienced cataract surgeons do a pediatric cataract, and they would end up finding that it was very elastic and the opening would be bigger than the optic. And I really didn't want my learning curve to affect any child adversely. So I have to thank Alex Levin, because when I was his fellow, he trusted me and allowed me to develop this technique while I was doing my fellowship. And there's published papers, which I'm showing you here. Essentially, if the child is under the age of around 4, you can make 2 stabs with an MVR blade. And the distance between the 2 stabs is essentially the opening of your anterior capsulorhexis. And if they're young, you push and you pull and you get a round rhexis. And here is, I think this child was 4 months old. Now, one of the things I want to mention is that it's really important that you don't put too much viscoelastic in. If you make it completely flat, the anterior capsule, you don't get that nice round rhexis. It tends to be a bit more oval, but it's okay when you start. If you're a little bit nervous, that's fine. So I've made 2 stabs, and I hope you can see them. Can you see my pointer, Savleen?
I cannot actually.
Okay, I'm going to put the laser pointer on then. There we go. So
Yeah.
I'd made a stab here and one here. And all I'm doing with the microcapsular rexus forceps is I'm pushing. And because the vector force is to the center, the tear follows the curvature of the lens. And then you pull. And the two meet. Now, what I want you to notice is it's really important that infants and toddlers have a paralysis for their general anesthesia, and that the CO2 is kept below 30 or below, because positive vitreous pressure is going to cause the iris to come out. If you don't paralyze them, the eyes roll up. And then if you use a stay suture, because the eye is elastic, you're deforming the eye and changing the relationship of the vitreous base to the lens. So it's really important that that's done. And you can see with the push-pull, you've got a nice round circle. I'm just showing the irrigation aspiration. Again, what I teach my fellows is you do what you do in simple cases, so that when it's a difficult case, you can still do it. And you'll notice I'm taking the peripheral lens matter out first in case there's an opening defect in the posterior capsule. So I use the nucleus to tamponade. So I'm going to move on now. In older children, what you find is that if you do that, just the push-pull, you tend to get a very oval rexus. So what you do is you make your two stabs, you push, then you pull, and you pull. In fact, what I do now is I push this up to halfway, and then I actually go to the pulling of this, and I use this to come around. And in children over the age of 4, I actually include the initial stab. And then when I complete this part on the left that I'd started, I include that initial stab up here. So this is showing that. This is a case of posterior lenticonus. And you see what I did there? I sort of enlarged the opening because I wanted a bigger flap. And I'm going to go to the left in a minute. There I go. And I push to the left. Now, people find this difficult to believe, but I've never had a fellow or myself lose a rexus by it running out to the equator, because the vector force is always to the center of the lens. Now, there is a video showing all the different techniques of how to deal with a small rexus. It's on YouTube under my name, if you want to look at that. But you see here, what I'm going to do is I'm going to run this rexus around, so I include the initial stab. That is just a precaution, because I found in children who were a little bit older, like 6, 7, or 8 sometimes, when my fellows were doing this, that they might get a little tear where the initial stab was. It hadn't happened often, but it was enough for me to modify the technique and include that initial stab when I complete this tear. Even if you just want to use one stab, the fact that you have 2 stabs showing you what the size is, it gives you a parameter by which to work on. Now, what I want to show you is what you want to end up with is with the lens in the bag. This is the posterior opening. This is the anterior opening. But the anterior opening has got to be smaller than the size of the optic. And you can see how nicely it is away from the iris. The reason why you want the anterior opening smaller than the optic is that children rub their eyes, they trampoline it, and the anterior chamber then bounces, and you can get lens iris capture, which is not a good idea. And here are cases where that has happened. What I want to show you here is when you remove the lens matter and you and then fill up the bag, there's your posterior capsule. Before you fill up the bag, the posterior capsule bulges forward because of the vitreous, and you have to be aware of that before you do anything, and that's why you have to use viscoelastic to fill the bag up. So I've doing a 2-incision push-pull on the posterior axis. I make 2 stabs, inflate Berger's space, and push the anterior hyaloid face away. And if there was ever a time when the 2-incision push-pull rexis makes life easier, this is it. You know, you push and you pull. You're always pulling to the center, and therefore you are never really losing or getting anxious and stressing yourself about the rexis getting too big. And all of my fellows learn to do this, having never done one usually when they've come to work with me. And you can see that I do all of the surgery, the majority of the times, from the limbal, corneal limbal wound. The posterior capsule can be a little bit elastic, and you mustn't be afraid of really, giving it a good tug. In this particular case, I think the child was 4 years old, and I tend to do an anterior vitrectomy up until the age of 5 after I've done the posterior rexis. What I want to show you, and this is a really important slide, is I've taken the lens material out, I've done the posterior rexis, I've inflated the bag. And when you inflate the bag in children, because the capsule is elastic, look how the posterior capsule is pointing downwards. If you put a lens in this bag and rotate it, that leading haptic will flip into the posterior capsule. You cannot rotate the lens when you open the posterior capsule first. You have to place the lens into the bag and place it in the leading haptic in the bag without rotation, and that's important. This was a paper written by a group from LV Prasad Eye Institute, where they used the push-pull technique for fibrous plaques, and I hadn't published it. I was glad that they did. This is very true. If you have a posterior plaque, I actually just make the stab at the edge and at the other edge. Then I inflate the Berger space. And the push and pull now works very well because the plaque acts as the template for the tear. I want you to notice that the iris is not bulging out. And this is because the CO2 is 30 or below, the child is paralyzed, and you've got total control of the intraocular contents. And basically you do the push and the pull, and you end up with your opening. Now, sometimes you might want to do, this child I think was about 5 years old, you may want to do an anterior vitrectomy if there are still these tethered areas that Marie-Jose Tessino has beautifully shown are part of a maldeveloped anterior hyaloid face, which is probably why they got the plaque. And you can then take the plaque out. So on that note, I want to say a big thank you. If you were interested in more pediatric cataract stuff, there's the WSPOS worldwide webinars and the WSPOS channel if you're at all interested in watching more pediatric cataract videos. Thank you so much, and I'm going to stop sharing.
Thank you, Dr. Ken. I think our residents and fellows would love to try and do what you have actually taught us today. Thank you so much. I would now invite Dr. Jagat Ram sir for sharing his screen, and we'll take questions at the end of the free talks.
Thank you, Dr. Savleen. First of all, I am thankful to Chandigarh Ophthalmological Society, particularly Dr. Jaspreet Sukhija, who is the president of COS, and Dr. Chintan Malhotra, honorary secretary of COS, for giving me this opportunity. Today, I am presenting this video management of the PHPV. which also received the Best of the Best award at American Society of Cataract and Refractive Surgery in 2016 at New Orleans. So first I will share the video and then I will, if there will be time, I will speak for 1 minute more. So video is already sound recorded, is sound.
In this video, we cataract associated with persistent hypoplastic primary vitreous. The producers have no financial interest in the subject matter of this film. Persistent hypoplastic primary vitreous is a congenital anomaly in which the hyaloid vasculature persists beyond fetal life. In cases of interior PHPV with visual axis obscuration, surgical outcomes have been dismal. The presence of a dense vascularized membrane behind the lens can lead to potentially disastrous complications like intraoperative bleeding, sometimes even requiring abandoning the surgery. We describe a surgical technique for the management of such cases to obtain a favorable visual outcome. After making a continuous curvilinear capsulorhexis, the cortical material is aspirated out. The persistent fetal vessels are then cauterized in a circular fashion to obtain an avascular cleavage plane. The membrane is cut along this cleavage plane with vertical microscissors, creating a posterior capsulotomy. The stalk with the hyaloid vessels is cauterized and cut along with a limited anterior vitrectomy. The IOL can then be safely implanted in the capsular bag. With these surgical principles in mind, let's take a look at some real-life scenarios we face in children with PHPV. First is a 3-year-old child who presented with a limited anterior PHPV, obscuring the visual axis with a classical stalk. Indirect ophthalmoscopy revealed a normal retina with the stalk attached to the disc. The axial length was 18.3 millimeters. After making the side and main port incisions, a continuous curvilinear capsulorhexis is completed using a Utratas forceps. Then the soft cortical material is aspirated out by irrigation and aspiration. A primary posterior capsulotomy is performed around the attachment of the stalk. The hyaloid vessels in the stalk are cauterized, followed by limited anterior vitrectomy. In view of the large posterior capsulotomy, IOL is implanted in the ciliary sulcus with capture of the optic in the rhexis margins. The viscoelastic material is aspirated and the ports are sutured. The second scenario is a 6-month-old child with a diffuse white cataract. Ultrasonography revealed the presence of a stalk extending between the optic disc and the lens, suggesting the diagnosis of PHPV and an axial length of 17 millimeters. The interior capsule is stained with tryphan blue dye and a continuous curvilinear capsulorhexis is made. The cortical lens material is aspirated out with the irrigation and aspiration cannula. This reveals the densely vascularized membrane with the stalk being visualized here on retroillumination. The persistent fetal vessels on the membrane are cauterized with the help of an endocautery to create an avascular plane. Vertical microcisors are then used to cut through this membrane 360 degrees, thus creating a posterior capsulotomy. The same endocautery is used to cauterize the hyaloid vessels in the stalk, and the remnants of the membrane are taken out after an anterior vitrectomy to release vitreous traction. A corresponding interior and posterior capsulorhexis can be visualized here. The single-piece intraocular lens is then implanted into the capsular bag. As PHPV is mostly unilateral, an IOL placement is desirable because unilateral aphakia is as strong a stimulus for amblyopia as the primary pathology itself. The third scenario is that of a 2-year-old child presenting with a densely vascularized membrane with large prominent ciliary processes. The initial steps of surgery are carried out in a similar fashion. A continuous curvilinear capsulorhexis can be particularly difficult in such cases due to the thin and lax nature of the capsule. The persistent fetal vessels in the membrane are cauterized in a confluent pattern to create an avascular cleavage zone. A posterior capsulotomy is made by cutting through this newly created avascular zone with microcisors aided with the help of intraocular forceps. Care should be taken to not cut through this thin stalk of fetal vessels at this stage. After completing the posterior capsulotomy, the fetal vessels in the stalk are cauterized and the anterior vitrectomy is completed to obtain a clear visual axis. An IOL can then be implanted into the capsular bag. Post-operatively, these eyes should be managed on higher frequency of topical steroids along with antibiotics and cycloplegics. Residual refractive error, if any, should be corrected and intensive amblyopia therapy initiated. Children with PHPV require a long-term follow-up to monitor for visual axis opacification, glaucoma, and posterior segment complications. To conclude, cataract associated with PHPV is a challenging situation. However, by following the basic surgical principles as demonstrated here, a favorable outcome can be achieved in a majority of these children. Thank you.
Actually, if we go by this procedure which we have carried out in these children, now we are following this surgical technique, and we have done more than 60 such cases in PHPV. But by the older technique, when cautery was not available and there used to be a lot of complication. So now the rate of complication has significantly decreased. And what we have learned from our own surgery is that cutting this posterior membrane after it is cauterized, even then it lead to a lot of opacification. It grow over a period of 6 months to 1 year, and it may need repeated posterior capsulotomy. So we have learned that we have to make the posterior capsulotomy larger in such a thick vascular membrane. That is one. Second thing is inflammation is also significant in these infant because so you have to give topical steroid and have to give a bit for longer period. And majority of the cases we implant IOL because these cases are unilateral. But if axial length of the globe is less and there is a significant posterior segment involvement such as retinal detachment or much more issues, then we do not implant IOL. As already said, axial length of the globe 10 millimeter, or corneal diameter 10 millimeter or more, and axial length 17 millimeter or more, we implant IOL. So rest, whatever question will be there, we will be happy to answer. Thank you very much.
Thank you so much, sir. It was an absolute delight to watch those videos, and you made very important points of a larger posterior capsular rhexis and taking control of the inflammation also in these eyes with PHPV. We have a few questions we'll take after the next talk, and I would now like to invite Dr. Jasprit for sharing his screen.
So this is the concluding talk, and just wanted to share something new what we've done. What I'd be discussing here is the ICAM in pediatric cataract surgery. So ICAM is what we used was the intracameral anesthetic mydriatic. Now this combination has been used in adults. So we know that success of cataract surgery is largely dependent on the adequacy and sustenance of pupil dilatation. But in children, the issue is more pronounced. Why? Because the dilator muscle is underdeveloped as compared to the sphincter pupillae. And intraoperatively, pupillary constriction poses a further challenge. So all the more the surgery becomes complicated. Conventionally, what we're using is topical mydriatics. The surgery is done around the world in children for dilating the pupils. People use the topical mydriasis. Now, what happens is with these topical drops, whether it's a 2-year-old child, a 5-year-old, or a 6-year, or maybe a 10-year, the dosing is universal across the age groups. Yes, in infants, we do modify the doses. They are associated systemic effects because they are absorbed by the nasolacrimal system, and so much of it goes into the circulation. There is a risk of allergy to these drugs. Atropine has been known to be allergic. Cyclopentolate allergy is known. You have preservatives in these, which is toxic to the epithelium. Then the absorption is an issue. In children, you have, even if it's a young child, the child may cry, and with the tears, maybe drain off the topical applied drugs. Children are uncooperative. Sometimes you have issues with corneal mucopolysaccharidosis, or maybe thicker cornea where penetration might be difficult. You have to have 3 or 4 drop preparations which are required for a well-sustained dilatation. That adds to the cost. Yes, and the other problem is you need dilution if you're using them in infants. So what is this combination which is currently available in India is by the name of phenocaine. So it's a combination of tropicamide 0.02%, phenylephrine 0.31%, and lidocaine hydrochloride 1%. This was originally used as midrange in UK, and we have a few studies in adults, but it's never been used in children. So adult studies, probably one of the largest trial was published in BGO, where they showed that the standardized combination produces rapid and adequate mydriasis, achieved a pupil size of 7.5 millimeters after a viscoelastic injection. It's less stressful, what they found for the patient, because putting drops could be, putting it twice, thrice could add on to maybe a little, the experience with the patients. They might not like it, or they might feel kind of irritated with it. So this would also increase the patient flow and the surgical team efficiency when they use the intracameral medication. The rate of capsular rhexis performed without the use of additional mydriatics with a pupil size of at least 6 millimeters just prior to capsular rhexis was high. That's almost 96.8% was the efficacy. So that is fairly high. And it was similar to the reference group. They did not have any side effect related to the drug. But there's no study in children. So we did have this phenocaine, which is approved by the drug controller of India. And we thought that why not do a pilot project and see the efficacy before going ahead with the larger studies. So this is the phenocaine plus what we used was from the Antod Pharma. And we had children ranging from 1 month to 12 years of age. 12 years of age. So I'll just show you some of the videos where it was used. And we'll discuss the advantages later on. So this is just a 4-month infant, and you can see the small pupil size here. So we just measured the pupil size, and it was like about maybe 1.5 millimeters, what would be shown on the caliper. Yeah, so that's just 1.5 millimeters. So once we inject this drug, we haven't given any topical drops here. And what we're going to use is we put this phenocaine in the tuberculin syringe and inject it a small amount and just see how the pupil would dilate. So this is a 4-month-old infant. You would have issues with pupillary dilatation, maybe with the topical drops as well. So I'll just move on the cursor and see how it's dilating. So it does take a little more time in infants as compared to older children. But yes, after putting viscoelastic, you get a fairly good pupil size, which was around 6.5 millimeters. I think we'll just have a look on the caliper. Yes, it's about 6.5 millimeters. So that's fairly good for performing a good capsulorhexis. And you put some more viscoelastic and probably the pupil size increased as well. That was almost 7. So a 7 millimeters pupil size in a 4-month infant is reasonably good. And you can see here the stability of the pupil. It's not coming down even when you're doing the irrigation aspiration. So we did not have any intraoperative pupillary constriction when we used the phenocaine plus. So it really helped us stabilize and gave us a consistent pupillary size for performing the whole surgery. And you can see the capsulorhexis, posterior capsulorhexis being performed here. But again, you can see the pupil size is fairly good. So our next patient is a 5-year-old child. As I just told you in the previous video that with infants, it's a little difficult as compared to older children. And we can see here when we injected the phenocaine, just see how beautifully the pupil is dilating. And it's fast, without any systemic side effects. I'll just move on my cursor to see. That's it. So you're having a fairly good glow, and we use a tuberculin syringe for injecting this drug. There you go. So in a 5-year-old child, we had a pupil size which almost reached up till the limbus, and it was maintained throughout the surgery. That was the anterior capsulorhexis, and we are performing the lens matter aspiration. You can see here the pupil is still almost the same size. It has not constricted. And this is when we are removing the lens matter. Still the same. And now we're going to perform the IOL implantation after a posterior rhexis. The pupil size still remains same. So that's the beauty of this drug. It does not allow pupil to constrict intraoperatively, that which you could have using topical drops. This is another one where obviously an older child had a subluxated lens, and you can see here, we can just see a small gap here. The subluxation is not that visible, and when we inject this intracameral combination, you start seeing the edge. Takes a little time, but then dilates very effectively, and the dilation is maintained. So that's it, and so it's dilating more, and we're able to see the stretched zonules here. When you inject the viscoelastic, it further dilates. So in older children with viscoelastic, probably the dilatation is much more as compared to younger children. And we are able to perform our surgery, whatever we have to, just removing the lens matter and the bag before finally. So here I had planned a iris claw lens, and we have to constrict the pupil. So we've dilated with an intracameral combination, and we're going to constrict it with an intracameral pilocarpine, and that's what we got. So a good constriction as well. So it's not that it will just maintain the dilatation and not allow it to constrict, but yes, it allows it to constrict with a small dose. So this is the posterior iris claw and the beautiful round pupil, what we got at the end of the surgery. Our next case is a patient of juvenile idiopathic arthritis. He had synecdoche all around. We did not use any topical mydriatics in this patient. And we can see here that I'm going to inject it That's it. This is an intracameral combination which I'm injecting. You can see here where there are no synecdoche, the pupil would dilate a little bit. Here it is on this side, it's dilating, and we have some amount of dilatation, but they are synecdoche, so probably we'll have to release them. But the important thing is that we did not use drops. This combination had an effect for dilating the pupil when we release the synecdoche. So the pupil did dilate. You can see here we're releasing the synecdoche, and they were released all around, and that's the pupil size what we got. And then you could just paint the anterior capsule with the trypan blue, perform a capsular excise, remove the lens matter, the pupil size still same. We did a posterior excise, and they are implanting the IOL. So that's the posterior capture what we're doing. And this intracameral combination has allowed us to do this without any constriction of the pupil. And this is probably the last video. This is a traumatic cataract in a young child. We have the ectopin uvea here, and when we did the cataract surgery in this patient, the pupil did take some time to dilate. So we injected it. You can see here it's starting to dilate. Took a little time. There it's dilating. I'm just moving ahead. There you got a beautiful round pupil. So it did take time, but yes, we did achieve a good, fairly big size of the dilatation of the pupil size. And you can see here it's not constricting, and when we're doing the irrigation aspiration as well, and the pupil, it's almost reached up to the limbus. So it really is very effective for maybe any kind of cataract surgery in children as well. And the results are really encouraging. So even when we are trying to aspirate the lens matter, the pupil is not constricting at all. And there we were able to implant the IOL. Yes, so we did not perform a vitrectomy, but were able to do a posterior optic capture where the haptic is in the bag and the optic goes behind the posterior capsule, which is evident by the oblong posterior capsule, which we can see here very clearly. And the pupil size, see, it's still maintained. So no pupillary constriction and a well-dilated pupil, and which allowed us to perform an uncomplicated surgery. So these are the findings of the few patients on which we performed used this intracameral combination. The pupillary dilatation of at least 6 millimeters was achieved in majority. It was a sustained dilatation, and there was no systemic side effects. So I would like to conclude here by saying that adequate and sustainable mydriasis is achieved with this combination safely in children. The advantage is it has a targeted drug delivery. You are going where you want it. No ocular surface toxicity because you're injecting it. No systemic side effects noted. COVID times, we started this project in the COVID times because the patients were being staggered. And when you put drops here, and if the patient is not taken up, or maybe there's a delay in surgery, your pupil is going to come down during surgery. So this combination helped us to tide over that time, that whenever the patient was taken out, we could be sure that at least the pupil would be dilated. Prior gonioscopy possible. Yes, we don't do just before surgery, but it is possible in an undilated pupil. We can dilate it using intracameral combination. It can be used in those patients who are allergic to atropine or cyclopentolate. And yes, we're not using 3 drugs. It's just one single injection. So it's cost effective, maybe 3 times less the cost. And this we published in the European Journal of Ophthalmology, and with all the encouragement from Professor Jagatram. This paper was beautifully compiled and published and written by, I must say, Dr. Sableen. And it's written so well that if you see here, date received says 3rd March and it's accepted on 9th March. I mean, this is the beauty of the idea and the way it's written. So, I mean, it's really something which one can try, and as is giving us good effects. We are moving on in doing a randomized control study in which we are using drops in one eye and the intracameral combination in the other eye. Thank you so much.
Thank you so much, sir. I think we have a few questions, and I would invite Dr. Sumita first because she wants to ask.
I just wanted to ask, did you use it in infants, and how was it any different?
You asking me?
Yes. I'm
Yeah,
asking.
so we've used it in the I can say something different which happened during COVID times was that we were getting many infants for cataract surgery, and we started using them just left and right in all these infants. And so we've done many, you can say many means a few cases, and the results are fairly good.
Any
Yes, and
trouble
those,
with the anesthetist?
pardon?
Any trouble with the anesthetist?
No trouble at all, because it's the dose. If you read this paper, this is an open access paper in the European Journal of Ophthalmology. We have even titrated the dose, and the dose is just 1 unit, 0.025 ml of a combination which already has such less percentage of the drugs in it. So even in adults, when they showed that with the 0.2 ml what they used, we use 0.025 ml. They've used 0.2 ml in drugs and have shown there is no detectable drug in the blood stream.
I can say this has excellent effect, and it has made the surgery also easier. Even in the adult, those who are not cooperative, where people is less dilated, it is effective in the adult also. So in children, I think it has shown excellent effect.
No, I completely agree. The surgeries looked very nice, and I was sometimes, but these are the questions which probably anybody would ask, because a lot of these dilatation drops, anesthetists give a lot of.
We were monitoring the heart rate actually with this. We had the anesthetist involved, and we did not see any significant change in the systemic parameters. If I might add, we also have a related question from the audience: comparison of phenocaine plus versus intracameral adrenaline. Dr. Jaspreet, please.
Yeah.
Advantages of phenocaine over intracameral adrenaline.
Yes. So the thing is that intracameral adrenaline has to be diluted in children. The other thing is obviously it's used. There's all off-label use and not really recommended for use in children. People have used it in patients who are not dilating, or intraoperatively those who had pupil reconstriction with the topical drops, and have shown good results. But yes, you have a combination which is available here, and with such a small dose where you don't need to dilute or do anything, probably has an advantage over using that adrenaline along with the topical drops.
There's also a paper which talks about the effect on the endothelium and how intracameral adrenaline can be detrimental to the endothelium. So I think there we have a economical availability of phenocaine plus, and we can use it. Every one of us can use it. Another question for I think Dr. Jagatram and Dr. Ken. What is the target when you have a patient of myopic shift? What is is there a cutoff where would you like to exchange the IOL? After a specific refractive error, is there a cutoff that you have in mind that now you would exchange the IOL? Dr. Jagatram, sir, please.
Yeah, we have seen this sometime even both the eyes, although our target refraction may be just +5 or +6, but we have seen unusual myopic shift in some of the cases. If it is -2, -3, -4, and it is bilateral, then there is no need of exchange for some time. But if it is unilateral, in some cases even unilateral, and there is a difference of 4 diopter or more, that is one of the indication. We have several of the children coming after 15-20 years that they are having -8, -9. Definitely there is a need of IOL exchange. But it is a process which take a longer time, and because we have a follow-up of the patient more than even 25 to 30 years. So we have seen so many patients. So if there is a significant myopic shift, definitely IOL exchange is required in such, if it is unilateral, definitely. If it is bilateral and similar, such as -3 both eye, then we can wait. I think there is no hurry for exchange. If it is more than -4 or so, then definitely we can go ahead with the exchange.
Thank you, sir. Dr. Ken, your thoughts on IOL exchange and when would you like to consider it?
So, I think I'm going to do a retrospective audit because I can't remember. Well, I've never done an IOL exchange. And I'm trying to figure out why my experience is so different from what people are saying. I do think that what I talked about, the lens capsule, I think there's a difference in my career. I think from 1999 to 2004, probably I would have cases if I was still in England that I would be telling you about. But 2004, I made the conscious effort of doing lens capsule polishing. To give you an idea, my fellows get very frustrated with me because it takes them like maybe 10 minutes to take the lens material out and then 15 to 20 minutes to do the lens capsule polishing. So I would say that if there was a unilateral case and the patient didn't want to wear a contact lens in their teenage years, I would prefer to put an ICL in the sulcus than to do a lens IOL exchange. Because an ICL in the sulcus can be changed very easily if you have to change it again. And any refractive surgeon can do that. So I have not had to do a lens exchange. And listening to the panel today, I am now going to go and do a study looking and seeing why that's the case.
Thank you. So ICL is another option that we keep in mind. Dr. Sumita, what your views on IOL exchange and myopic shift?
I probably have done few IOL exchanges, but the reason was not refractive in them. Either they were not placed properly or decentered IOL. Those I have removed and put it. But my cutoff for doing a lens exchange for -4 would be too low. So unless it's a really large myopic shift, I would not consider doing it. And a lot of these children, by the time they are 18 and 19, sometimes it may be possible to give them a LASIK or ICL, a refractive correction, rather than doing an IOL exchange, which is a fairly traumatic, especially if you have put the lens in the bag. It's not pleasant to take it out of the bag. And related to that, I'll just ask one question to here. Have anybody had to do IOL exchange for glistenings? Because a lot of my patients, thanks to COVID, there has been some dredging up of the old follow-ups who might have been in 2003 and 4, and a lot of them have glistening. So far, nobody has lost their BCVA, but the lens looks quite opaque and they are still teenagers. So would anybody consider removing IOL for this reason?
A very good question. Glistening and then
anybody, especially the single piece foldable lenses. I've had a lot of trouble. I mean, they don't look nice now.
We do have papers that describe less glistening with some IOLs. Dr. Jasprit, your opinion, please. Glistening and the need for IOL exchange because of the glistening?
IOL exchange for glistening.
I would like to ask which IOLs were these? I mean, this particular one IOL, or it's like different IOLs?
Mostly single piece acrylic IOLs. I have had IQ actually the worst offender.
So what,
but I've never put that many IQs, to tell you the truth.
So probably patient was having like a white reflex or what with the glistenings? How was it? Or the patient?
The lens doesn't look crystal clear, like say a 3-piece IOL will look. So I just wanted to ask panel's experience here, because they're all, including Dr. Chintan, who has probably.
I would not do exchange for this. I mean, in case it looks cosmetically, if the patient is bothered or it's causing a decrease in visual acuity or some kind of a contrast, the patient is bothered with a lot of glare and some stuff like that. Probably, I mean, my approach would not be to perform an IOL exchange.
I think, sir, we could hear Professor Jagatram's opinion on this.
IOL opacification, sir.
Yeah, no, actually, first about these crystals within the IOL, I have documented at least 3 of the patients where there is a significant crystallization and they are the shining crystal, as there is a as it is found in complicated cataract, much more than that we have documented. So these I have done IOL exchange in these three children I remember, and opaque IOL, many of them, although I don't use hydrophilic IOL, but there was some of the people outside, not at our institute, they used these hydrophilic IOL in the past, and we have done few dozen of IOL exchange so far. These I am saying opacification of the hydrophilic IOL. But these crystals are different. They may be found even in hydrophobic acrylic IOL.
Thank you, sir. Dr. Ken, any incidents of opacification of glistening?
I'm beginning to think that I might be an outlier here. So I have used the same lens since 1991, both for adults and children. That is the 3-piece hydrophobic acrylic made by Alcon. I have no financial interest in it, but in my entire career, I've used 11 one-piece lenses. And the reason why is that David Apple wrote a paper in 1994 in the Journal of Cataract and Refractive Surgery about IOL design and materials for pediatric cataract. In that paper, he wrote beautifully and very clearly that a one-piece lens has very poor haptic memory compared to a 3-piece lens. And stretching the bag has an effect on the amount of inflammation and the amount of contraction of that bag on a hydrophobic acrylic lens. And the other thing is that I do not see the point of using a one-piece lens. You open it, you're about to put it in, and then you realize, oops, the posterior capsule is not stable. I'm going to put it in the sulcus. You know, if you put a one-piece lens in the sulcus, it's going to decenter. So I cannot see the logic in having anything but a 3-piece lens at hand. And I'm willing to have any of my wonderful colleagues on the panel convince me otherwise. But why would I want 2 lenses in my OR when one lens is going to do the job every time? Even if you do optic capture, you cannot do optic capture with a one-piece lens. So somebody explain to me that if I want to save money and run an efficient OR, why would I want 2 types of lenses when one lens can do everything?
That's because the power of the lens, you don't get a 3-piece above 30 diopters. So if it's like 35 diopters or so, you have to use a single piece.
But just breathe. I would say to you that if you're using a 35-piece and it's a child over the age of 18 months, it's a non-ophthalmic eye. If it's a child under the age of 18 months, let's say it's 4 months old, that eye is going to grow 3.75 millimeters in 18 months. You only have to get that child through 12 to 14 months with glasses, and you're not going to need strong glasses anymore.
Yeah, the glasses is an issue here.
You mean that none of these lenses are in the sulcus. What I was mentioning was all in the back.
I'm just saying.
Visual access.
This is, I'm discussing this like family, right? I'm like a Tet Punjabi. You know, Chandigarh is my city. I always come to Chandigarh when I come to India. But I'm just saying, somebody needs to explain to me what the logic is of using a one-piece.
I'll tell you the logic. There is a bit of learning curve with 3-piece IOLs, especially with an open posterior capsule. And if you're using a less cohesive OVD, which is what is available to a lot of practice.
I agree with you. That's the best.
That is one and single. I'm also putting it the Punjabi way, and why we are doing single piece IOLs here, because 3-piece IOLs, a lot of people are not very comfortable putting it, and you really need a little bit of skill. I mean, a single piece IOL is an idiot-proof lens.
Okay, fair enough. Then I should be
places here where you have an inventory of IOL. So I agree that if you don't have an inventory of intraocular lenses and you have to choose one, so maybe perhaps 3-piece would be the thing that you order.
What is Professor Jagatram's experience, sir? What are your indications, single piece and 3-piece?
I am using both the types of IOL, and I find it easier to, if once there is a perfect anterior and posterior axis, it is easier to put a single piece IOL into capsular bag than 3-piece IOL. This is what I'm saying. And
that, then you can imagine the rest of us.
Also saying I agree with her, but single piece IOL definitely sure short I can place even in complicated situation, but it has to be within the bag, not in the sulcus. 100% it has to be within the bag. But if there is larger posterior axis or lot of problem, then I think it is better to put 3-piece IOL and make optic capture. Means place the optic within the capsular bag. But by and large, single piece IOL with surgery.
So, Dr. Jandaram, I'm a big fan of yours. You know that whenever I have a chance, I've taken your videos, I've played them. I think they're amazing. I think you're an amazing surgeon. But not everybody is an amazing, gifted surgeon like you are. And I think that what I'm trying to do is develop a safe pediatric cataract program so that people who are not as gifted as you are, who are not doing 500 cataracts a year, can still give the child a safe outcome. That's my goal. And I would say to you that if you agree that in the complicated cases, the 3-piece lens is a better lens to put in, then my motto is you do in the simple cases what you need to do in the complicated ones, so that when you have a complicated case, you're not having to think. It's all muscle memory. And for me, that I tell my fellows, that's the Mr. Miyagi moment. There was a movie called The Karate Kid, where the kid was told to wax on and wax off the car, and he got upset. He said, "Why are you making me do this?" And his teacher attacked him in karate, and he made the same movements to protect himself that he was doing to clean the car. So I believe that you should do in the simple cases what you need to do in the complicated cases, so that when you really need to do it in the complicated cases, it's muscle memory. That's my belief.
Thank you so much. So I think before we wind up and I hand up to Dr. Chintan for a thank you note, I would just ask one final comment from the panel. Dr. Sumita, I'll begin with you. One last comment about the webinar and anything you would like to add.
I think you should not be afraid to leave the child a faking. That's all. A lot of times there is an excessive pressure from the parents and from other doctors that if IOL is not there, child will not see anything. So I think there is no harm in leaving the child a phakic rather than doing a badly done pseudophakic eye. So I think a lot of us are very afraid to leave the children a phakic, and it is nowhere reflection on your surgical skills or anything that you did not put the IOL. I don't know how we all are probably more than 1,000 cataract surgeries here. With everyone on the panel probably has done more than 1,000 pediatric surgeries, and for us it's probably spinal level. But if you're doing it for the first time, you should do what works best in your hands. So if you think child is, I would rather leave it without IOL, it's always possible to do a good clean aphakia, and you can always put an intraocular lens later on when the child is a little older. So I think one carry home I would say is don't be afraid to leave the children aphakic, especially infants. I'm talking more in terms of.
Thank you. Good surgery, aphakia over a bad pseudophakic eye. Dr. Jaspreet, please.
I have only one thing. Let's get over these drops, use the combination. Let's move towards dropless cataract surgery. And you can say the inconvenience caused to the parents rather than the children. Let's get them over it.
So we have a new message, a dropless pediatric cataract surgery. Dr. Ken, please.
Oh, gosh. I think that when you do pediatric cataract surgery, you have to remember that everything must be done slowly and carefully, because the consequences of your surgery could last 70 years. And so taking the extra 20, 30, 40 minutes, when you look at the span of the life of the child, is nothing. There's no rush, there's no gain in finishing the surgery quickly. You have to finish the surgery well.
Thank you. Good and slow meticulous surgery. Dr. Jagatram, sir, please.
Yeah, definitely, I think it has to be meticulous surgery. It may take time, does not matter. Time is secondary issue. As Dr. Ken also said, that it is the safety, overall safety of the child which matter. And these children should be followed for a very, very long time. Once I think even if it is a successful surgery, child can develop complication tomorrow if they are not followed. So I can say that meticulous surgery and long-term follow-up, it is very, very important.
Thank you, sir. So it's not important that we do a good surgery. It's very, very important that we see the children post-operatively and tell them that they require a long-term, maybe a lifelong follow-up with us. That is also a responsibility as pediatric cataract surgeons. Thank you so much, everyone. Thank you so much, Dr. Jaspreet, for giving me this opportunity, and Dr. Chintan. Over to you, Dr. Chintan. Thank you.
Thank you, Sivleen. And I think it's been a wonderful webinar for all those doing pediatric cataract, and even for a person like me who doesn't really do pediatric cataract. So much to learn, so much to gain. I would like to thank all our speakers who've taken out the time on this Sunday morning or evening, as the case may be for them. Professor Lambert and Professor Maria had to leave us a little early. Thank you, Dr. Ken and Dr. Sumita, for staying on till the end. And last but not the least, thank you to Professor Jagatram. He's these days so busy, one can just imagine, with the COVID crisis and PGMR being a COVID hospital. Thank you, sir, for taking out the time and sharing your experiences with us. At the end, I'd also like to thank Entod Pharma for supporting this webinar. They've supported us earlier, and we look forward to their support in the future webinars. Thank you very much, and a good night, good evening, as the case may be. Thank you.
Thank you.
Thank you. Thank you, everyone.
Thank you, Dr. Jaspreet.